I'd like to introduce Dr. Paul Burchard, who is from the University of Rochester Medical Center and was on the team that did a lot of the preclinical work with PXS 5505 in the liver cancer models. And he's going to take us through why PXS 5505 makes a lot of sense in that disease.
Great, thank you for that introduction. Let me just upload this. Okay. So, hi everyone, my name is Paul Burchard. I'm a current general surgery resident and tumor immunology fellow within the Department of Surgery at the University of Rochester. I'm joined here today by Dr. Nabil Badri. He's a medical oncologist here and he's the principal investigator for a trial, as well as Dr. Hernandez Alejandro. I'm not sure if he's here yet, but he is coming, and he is the chief of solid organ transplantation at the University of Rochester as well. Today, I'm going to discuss with you all of our rationale and clinical trial design for the use of PXS 5505 combined with first-line therapy for unresectable and metastatic hepatocellular carcinoma. Outline is very similar to Dr. Hobbs's presentation, just in the context of primary liver malignancy. We're going to discuss what that is and how that relates to hepatocellular carcinoma, the current standard of care and how that has evolved over the past just 1 to 2 years. Then we're going to look at lysyl oxidase inhibition in hepatocellular carcinoma, as well as a primary liver malignancy model that we have here. And then I'm going to go into detail about the trial outline that we've developed over the past year. So primary liver cancers have doubled in incidence over the last 2 decades. In part, this is due to the increasing incidence of non-alcoholic steatohepatitis with the obesity epidemic, particularly in the United States. Primary liver cancer is currently the 4th leading cause of cancer-related mortality worldwide, and it's actually expected to surpass colorectal cancer by 2040. Hepatocellular carcinoma accounts for 90% of these tumors, with cholangiocarcinoma accounting for the remainder. And cholangiocarcinoma has a lot of features that are similar to pancreatic ductal adenocarcinoma, which you're going to hear about in a following presentation. Right now, the 5-year survival of primary liver malignancy is around 20%, which is dismal. Liver cancer is now the 2nd most lethal tumor after pancreatic cancer. And in both cases, surgical resection offers the best chance of cure. However, patients with hepatocellular carcinoma may present with disease outside of transplant criteria, resection criteria, or they stand to wait too long of periods for liver allograft allocation. Beyond resection, effective systemic therapies are lacking, which I will show you shortly, and thus new systemic strategies are a dire clinical need. The pathogenesis of hepatocellular carcinoma is very interesting, particularly with the onset of fibrosis and scarring of the liver, as we know that lysyl oxidase contributes to this. And so most often hepatocellular carcinoma develops as a result of chronic inflammation that leads to fibrosis and subsequent cancer development. And a prevalence of cirrhosis among hepatocellular carcinoma patients is upwards of 95%, and cirrhotics undergo surveillance imaging and develop hepatocellular carcinoma 2 to 4% per year. And this is also caused by the various hepatitis viruses, including hepatitis B and C, as well as alcoholism and the non-alcoholic steatohepatitis that I talked about earlier. Most patients with hepatocellular carcinoma are unresectable at initial presentation, and until recently, the only approved first-line therapy was sorafenib, which is a tyrosine kinase inhibitor, which had really mildly improved overall survival that you can see on this graph here on the left, really not that much improved compared to placebo. And the time to symptomatic progression was ultimately not improved whatsoever. However, sorafenib was first-line therapy for a significant period of time until recently. There are two recent trials that have been introduced in the last 1 to 2 years that are essentially changing the landscape of treating this disease. Those trials include immunotherapy options for hepatocellular carcinoma and are now at the forefront of combating HCC. The Himalaya trial combined both anti-PD-L1 and anti-CTLA-4 therapies and found a 22% reduced risk of death compared to sorafenib alone, as well as a response rate of 20% versus 5% with sorafenib. In addition, the I Am Brave 150 trial combined anti-PD-L1 with anti-VEGF therapy and was recently published in the New England Journal of Medicine just 2 years ago, with significantly improved overall survival and progression-free survival. As such, these therapies are now replacing sorafenib at many institutions and offer an attractive backbone to pair with therapies that may boost immune responses as well as drug delivery. And you'll soon learn that this combination of anti-PD-L1 and anti-VEGF therapy is the backbone that we are using to build our trial. Lysyl oxidases, as I'm sure many of you are aware of, are a family of 5 secreted enzymes. This is LOX and LOXL 1 through 4 that catalyze collagen cross-linking. In the context of solid tumors, this process becomes dysregulated in tumorigenesis and leads to increased tumor stiffness, decreased drug perfusion. Additionally, lysyl oxidase has been shown to play a role in increased tumor growth, epithelial to mesenchymal transition, angiogenesis through that VEGF expression, invasion, and metastatic spread. Lysyl oxidase expression in hepatocellular carcinoma tumors has been shown to correlate with worse disease-free and overall survival. And this has been shown in both small and large studies across different countries. Multiple research models of hepatocellular carcinoma have further emphasized this correlation. Furthermore, high lysyl oxidase expression within the tumor microenvironment of hepatocellular carcinoma correlates with metastatic spread and recurrence rate after resection. In particular, LOXL2 is upregulated highly in hepatocellular carcinoma and has been shown to correlate with intrahepatic spread and metastatic spread. Researchers have utilized LOX inhibition in mouse models of highly fibrotic tumors. This is pancreas tumors, cholangiocarcinoma tumors. And this selective inhibition disrupts the fibrosis and collagen content of these tumors and ultimately leads to improved drug delivery. Furthermore, this lessens the stiffness of the tumor matrix and has been shown also to improve anti-tumor immunity. This is data that I'm presenting from our own lab here at the University of Rochester, where we have studied LOX inhibition using PXS-5505 in a mouse model of primary liver malignancy. These mice develop cancer within the liver spontaneously, which we identify using high-frequency ultrasound. Then the mice are enrolled into treatment regimens of weekly chemotherapy with or without PXS-5505. And within this model, we've seen tumor growth and ascites onset delayed with the addition of PXS-5505, and most importantly on the right, overall survival significantly improved with the addition of PXS-5505 to this chemotherapy backbone. Further investigations of this work has demonstrated improved penetration of the chemotherapy in these tumors, as well as enhanced anti-tumor immunity, which makes PXS-5505 an extremely attractive option for our patients with hepatocellular carcinoma who will be started on systemic therapy that targets these similar pathways. This work has now been presented at multiple national and international meetings with experts in oncologic disease and has been met with significant enthusiasm. As such, our trial design was accepted for presentation at the most recent American Association for Cancer Research meeting on the advances in pathogenesis and molecular therapies of liver cancer. This trial design is a phase 1b/2 design for patients with unresectable and or non-transplantable metastatic hepatocellular carcinoma. The IND for the trial received FDA approval in September of 2021 and has been undergoing regulatory meetings and arrangements since in order to initiate enrollment likely during the summer of this year. The phase 1b cohort will require approximately 18 patients to achieve a total of 12 at the maximum tolerated dose. The backbone in this trial is going to be atezolizumab and bevacizumab, which are those anti-PD-L1 and anti-VEGF therapies, which are dosed at 3-week intervals. As such, patients will be evaluated each 3 weeks for toxicity and to adjust dosing accordingly. Furthermore, we will evaluate for progression through routine surveillance imaging. And if we identify 4 or more treatment responses among patients at the maximum tolerated dose, we have the rationale to expand into a phase 2 study, looking at the efficacy of this combination therapy. The phase 2 expansion cohort will include a total of 42 patients at the maximum tolerated dose. And at any point during enrollment, should we have difficulty with patient volume, we have the resources and contacts in place to expand to additional centers within the United States. As is critical in these endeavors, we obtain baseline and on-treatment biopsies to better understand how we are modulating the tumor microenvironment in this disease. For the phase 1 portion of the trial, this is a representation of some of the key inclusion and exclusion criteria. There are many more, but these are some of the most important. Importantly, these patients cannot be considered resectable or transplantable for their disease. However, they can have undergone first-line therapy with local regional therapies, such as SBRT, which is radiation, transarterial chemoembolization, etc. In addition, we're limiting the enrollment to Child's A or less cirrhosis, which is a marker for the functional capacity of the liver. This is for the safety of the patients that are enrolled in a new drug combination. In addition, given the mechanism of action of PXS-5505, we're excluding those patients with connective tissue disorders, evidence of aortic aneurysmal disease, or those that have gone in recent major operation. We'll have 3 dose levels. These are based on what we've learned from the use of PXS-5505 in myelofibrosis with excellent target engagement, particularly at 200 milligrams twice a day. And this 3 dose levels also allows for earlier maximum tolerated dose determination. This is a representative diagram of the flow for this trial. Essentially, to walk you through it, patients will be identified at our cancer center with imaging or biopsy findings consistent with the inclusion criteria for our study. They'll be enrolled in our clinic and undergo a pre-treatment biopsy, either through interventional radiology or endoscopic means, if they do not already have a biopsy performed. As this is not standard of care for HCC, however, we have personnel in place who are experts in this area to minimize the risks of these patients. They will undergo on-treatment biopsy around the same day as their on-treatment imaging, and beyond the 43-day interphase, they can continue on their treatment regimen for a period of up to 2 years. Looking specifically at the 3-week intervals, we plan to enroll 2 patients at each dose level prior to safety determination. If there's a dose-limiting toxicity at a particular dose level that cannot be attributed to the atezolizumab and bevacizumab, the dose will be de-escalated. Otherwise, dose escalation will occur until 12 patients are evaluable. This is a very busy slide, but essentially is demonstrating our criteria to expand into phase 2, which will be important for the determination of efficacy of this drug combination. So as mentioned previously, if we observe 4 or more responses based on well-established RECIST imaging criteria, we will expand and enroll 30 additional patients at the maximum tolerated dose for a total of 42 patients. The phase 1B portion of this trial is based on the Bayesian optimal interval design, which is designed to determine how to enroll patients and when their dose-limiting toxicity adjustments need to be made. And we have targeted that with a 0.3 DLT rate. Thank you for your participation. We'll be happy to field any questions that you have.
Thank you very much, Dr. Burchard. Our panelists are the same as before, so they will rejoin us now, and ask any questions. I'd also like to just remind the audience that if you do have particular questions, feel free to add them to the Q&A box, and to the extent that we can make sure we cover those, we will as well. So why don't we kick off with the questions? Maybe Hassan.
Yep, thanks, Michael. Hi, Paul. Just a question on other drugs that have treated this particular pathway, or have there been other drugs developed that target fibrosis and been trialed in cancer? Because what have you discovered when you studied those drugs, and how is PXS-5505 different from those drugs?
This is an excellent question, and it's one that has been studied in the context of pancreatic cancer, particularly with targeting high hyaluronic acid. And ultimately, that combination of high hyaluronic acid with chemotherapy did not succeed in the context of pancreas cancer. But I think there are multiple reasons why this failed that aren't attributable to PXS-5505. One of which is that those patients had a lot of off-target effects, and high hyaluronic acid resulted in thromboembolic events, pulmonary embolisms, deep vein thromboses that ultimately limited the number of cycles that patients could undergo for their chemotherapy. In addition, a lot of recent research in these cancers that have this dense stroma has focused less on the hyaluronic acid component and more on the collagen component. And as far as we know right now, no one has specifically been targeting these collagen components with a safe compound in humans for these kind of GI solid malignancies. And that's why we think that this pathway is the safe and more effective pathway to choose.
Yeah, and in terms of stratifying patients for the clinical trial, is every hepatocellular carcinoma patient going to have a fibrotic disease, or is there kind of heterogeneity where you'd have to select a certain group of patients with HCC?
Not every, Dr. Burchard, do you want to answer this one?
So definitely there is heterogeneity in terms of because the mechanism of hepatocellular carcinoma is in chronic inflammations and fibrosis anyway. But those patients, hepatitis B, hepatitis C virus, and patient with just NASH. So definitely there will be heterogeneities, and probably we will run some sub-analysis to find out about the efficacy of our combinations with those subcategories for our patient. But we'll be enrolling for all patients, regardless of their underlying cause for the HCC.
Great, I'll jump back in the queue.
Eric, do you want to go?
Yeah, maybe I can jump in. I really appreciate the presentation on going in depth in your trial design. It's really refreshing to see that depth of detail. Thank you. Just on that trial design, as far as in the dosing and schedule, can I get into a little minutia? As far as the dosing of 5505, obviously it's dose escalation trial 2 times a day, but the dose schedule is 43-day interphase. Why was that chosen? And is that do you feel it's obviously long enough to see any kind of changes in the fibrotic nature of these patients? Because they are cirrhotic as well, because I can see the Plough A compensated liver cirrhosis for the inclusion criteria. I'm just trying to get your thoughts on how that trial was designed, what your thought process is on the length and the dosing. Thanks.
That's a great question. The reason for the dosing interval that we chose is because the atezolizumab and bevacizumab are a once every 3 weeks dose. And so we wanted to make sure that these patients at least got 2 cycles of that while they were also getting the PXS-5505. The dose-limiting toxicity, however, is going to be determined just after the first 21 days of treatment. And then the patients can continue on the PXS-5505 in combination with those therapies for 43 days as the phase 1B cohort, and they ultimately would undergo surveillance CT imaging anyway while on treatment with those two medications at 2 to 3 month intervals. So that's where that on-treatment biopsy came into play, was that, well, if we're getting a CT scan on these patients anyway at 2 to 3 months, we can take advantage of that and get a biopsy the same day, even perhaps using our interventional radiology colleagues at the time of the CT imaging. So that's where that rationale came from. We agree that the degree of fibrosis that we may be looking to change may be modest at that point. But it allows us a safe and effective window to see not only how it's affecting fibrosis, but also how it may be affecting the immune profile of these tumors by immediately bringing these samples back into the lab and running them for various flow cytometry, RNA sequencing, and immunohistochemistry techniques that we can do that day in the lab.
No, that makes total sense. Thanks for that. And just quickly, sorry if I may, just on the tox profile of Bev, I mean, obviously in that combination, that's what I think is the biggest AE. And did that catch you right by saying you can dose titrate both of those as well, especially Bev? If you say some DLTs, you can pull that down. Did I catch you? Did you say that? Sorry, I missed that.
I didn't say that, but that's exactly right. So if we identify a toxicity that we can attribute to bevacizumab or atezolizumab, but obviously Bev is the more serious medication that requires a lot of close surveillance, especially with the hypertension that it can cause. If we can attribute to that, we can dose de-escalate that medication while not adjusting PXS. And in addition to ensure some safety for these patients, we do have a surveillance endoscopy before enrollment that all treatments with that would be placed on Bev would get anyway. And so that is part of the treatment regimen to make sure that we look for varices as well.
Maybe Dennis, or you'd like to ask something if you've got any questions?
Yeah, thanks very much. First question is just a clarification on the trial design. You mentioned that you need to have 4 responders at the maximum tolerated dose for progression. So I was just checking, is that 4 out of the 12 at the maximum tolerated dose, or 4 in total in the that component of the trial?
It'll be 4 out of the 12 at the maximum tolerated dose. If somebody is at the maximum tolerated dose, but we haven't enrolled 12 patients, we don't know that's going to be the maximum tolerated dose, they will have continued anyway on the treatment and gotten their surveillance imaging. So we will have data on them at that interval. Someone can't be up titrated to the maximum tolerated dose and then be enrolled as a maximum tolerated dose if they started lower, like at 100 twice a day, and then ultimately we get to 200 twice a day. Once we have 12 at 200 twice a day, then we can look at their CT imaging and decide, did we have 4 with an objective response and can we expand?
Mm-hmm. And you mentioned that objective response is your primary efficacy endpoint that you're looking at. What are the other efficacy measures that you'll be particularly interested to follow in these patients?
I think when we look at them, we're going to want to make sure that their functional status has remained positive. That's always going to be a important marker for hepatocellular carcinoma patients who can develop ascites, like in our mouse models, where they can develop ascites, they can get poor ECOG scores, and so we're going to look at those kind of functional outcomes. For me in particular, it's going to be looking at the tumor microenvironment changes and looking for efficacy changes within the tumor, whether that's immune profile changes or stromal changes that can help guide us moving forward, not only with this compound, but with any therapies in the context of this disease.
Okay, thanks very much. I'll pass the baton on. Thank you.
Bianca?
I've got a more higher level question. So the trial size is 18 patients, I guess the first part, the 1B. And it's open label. How easy is it to decipher for example, the objective response? That's one question. And then the next question is, what do you expect? And if you look out at the, not so much the approved one, but more the drugs that are in development there's a hell of a lot of different combinations that are being studied for this. How do you put that into context, what response rate you're expecting?
So right now, if we look at the New England Journal paper and we look at the combination of atezolizumab and bevacizumab, we see an objective response rate that has become standard of care, but it was really only 27% within that patient population. So it's still pretty poor. There are lots of different immunotherapeutic strategies ongoing. That Himalaya trial is very recent, and it was just presented at the American Society of Clinical Oncology meeting, and so it hasn't even been published in a manuscript yet. That's just an abstract. But so immunotherapy is booming, as it is in many other different malignancies, and so I think we are catching this at the forefront of the introduction of immunotherapy for HCC, and going after it this early is we're kind of lucky that the first line therapy changed right at the same time that we were targeting writing a trial with this compound. As for the question about the objective response rate, that is really determined by the iRECIST criteria, which is ultimately it is truly objective. There won't be subjective component to it, so it is a primary endpoint that we're looking at, and so that is determined by growth or complete or partial response to the tumor in the liver, and that's measured by a radiologist, and is not really a patient-reported outcome, so it should truly be objective, even though this is an open-label trial. Now, the other secondary endpoints that we look at, like their functional status, could absolutely be manipulated by knowing that they're on a trial with a drug, but the objective response rate should truly be objective based on the iRECIST criteria.
The one thing that we've seen a lot is the open label. They show objective response rates and they usually look better, but then when they're confirmatory trials, which are basically blinded or basically a bit different, they don't really confirm it. So is there any way that you can, I don't know, increase the likelihood that what you see is real, given, look, 18 patients isn't that much? Is there anything you can do, or what to get more comfortable with what the outcome may be? And I guess the next question is, what do you see? Do you look at 27%, 30, 35, 40? What are you looking at, or what you think that you may get?
Well, first, one of the ways to help mitigate that, doesn't exactly answer your question, but there are checkpoint inhibitor related changes to tumors on imaging that can be called pseudo progression. And so to confirm that a patient either responded or didn't progress on the disease, we are going to get an additional CT imaging scan within a certain time frame afterwards to confirm their response. So although that doesn't answer the bias question, that does answer at least a understanding from the imaging standpoint. As for the patient volume size, I agree. I think that this trial is designed aggressively to hopefully expand into phase 2, and knowing that this phase 1 response of 4 patients is almost just a marker to expand and try and bring in a total of 42, so that we can get a better look at it. Right now, it is powered to have a rather robust response in phase 2, but that was obviously to avoid having to enroll hundreds and hundreds of patients to try and see major response. I think if anything, we use this trial to guide us and maybe give us rationale to go into a phase 3, and get a look at it from an early efficacy standpoint.
Yep, great, thank you.
Just want to add one more thing to what Paul was mentioning, that this is a patient with HCC, usually a sick patient in general. And the idea of PD-L1 and immunotherapy for those population was really explored in many clinical trials. Honestly speaking, like many of them failed to show some improvement or better than the sorafenib alone. And that's why the idea about combining the PD-L1 is to have a good safety profile in general, but combining the PD-L1 inhibitor with something else to enhance the efficacy in patients with HCC. This is what's coming with the BEV inhibitors, with the VEGF inhibitor with the BEV, also with the lenvatinib, which is a TKI plus pembro. And for our trial, PXX actually have a good safety profile for this sick populations, make a lot of sense for combining this regimen for patients with HCC. In terms of the objective response rate, yes, as Paul was saying, it's very difficult to get with 12 patients, but our expansion hopefully with the good numbers of patients, we will include the first 18 patients with the 30 patients, and we have a good number of patients to assess the objective response rate.
Great, thank you.
Thank you very much, Dr. Burchard and Dr. Badri as well for that.